Good morning, everyone. Thank you so much for joining us at the webinar on Maryland Prenatal Risk Assessment, Linking Pregnant Women to Needed Services. My name is Sadia McKeith, and I will be hosting and facilitating with this webinar with Maya McDoom. Our objectives with the webinar are to explain what the Maryland Prenatal Risk Assessment is, why it is completed, and how it is used by our local, state, and health departments to initiate care coordination for pregnant women. We will explain what the COMAR regulations are, Medicaid requirements, and the benefits of completing the prenatal risk assessment. Our goal is to ensure that as pilot sites are interested in this work, that they have key next steps in order to move this work forward. I'll go ahead and pass it over to Maya.
Good morning, everyone. So just a quick overview of what our program will be today is that we will start off with Dr. Shelley Chu and Mrs. Marion Pierce, both from the Maryland Department of Health, talking about the prenatal risk assessment and Medicaid overview of the COMAR regulations. We'll then transition over to a few case studies with folks that have actually transitioned from the PRA paper form to the ePRA system. And then we'll transition over to our local health department, ACCU partners, to talk about their experiences and the services that are offered to women. And finally, we'll wrap it up with the next steps in terms of how we actually scale and transition over to the ePRA pilot, and close out with a Q&A facilitated by myself and Sadia. Next slide.
Hi, everyone. Good morning. My name is Shelley Chu, and I'm the director for the Bureau of Maternal and Child Health, which is in the State Health Department and under Public Health Services. And thank you so much for the opportunity to talk about the Maryland Prenatal Risk Assessment. And we first wanted to talk about why the prenatal risk assessment is so critical. So as many of you know, that the social determinants of health influences nearly 80% of our health outcomes. And so what you can see on the slide, that really that healthcare access and quality, that neighborhood and built environment, the social and community context, the economic stability, and really the education access and quality. And so also that this is an opportune time. Pregnancy is a vulnerable time for both the pregnant person and the fetus as well. And so addressing those social determinants of health, addressing those social needs is a key opportunity to intervene. And then third, just really on that population health level, there is a statewide integrated health improvement strategy that many of you have already heard. And so this is really a critical time to collaborate, to streamline our health systems to better serve communities, improve healthcare quality, and manage costs of care. And so that strategy, the state has submitted a proposal to really improve maternal and child health outcomes, including maternal and infant health as well. And so the Maryland Prenatal Risk Assessment is that critical piece to link care. So the next slide, please. And so it is a form with the potential to save lives. So here is a snapshot of the form that many of you have seen. And so just to review what the form contains, it includes a contact information. And of note, the phone number is a primary way for the local health department, so specifically the administrative care coordination units, to reach out to the patient. It also collects demographic information, the person's birth history, psychosocial risks, such as tobacco or substance use, if they are experiencing housing instability, late stage of prenatal care and lack of transportation, and also medical risks, hypertension, diabetes, sexually transmitted infections, genetic disorders, and mental illnesses as well. And so we just wanted to show the form and the components that are included in the form as well, and just how important this form is. And so what happens when one completes the form? So the next slide, please. is that it really, that form really captures information about the pregnant individual eligible for Medicaid services. And then it really helps connect them to care. And so here are the various ways that the form is being used. So first on the top with the managed care organizations. So with the managed care organizations and specifically with the special needs coordinators, it allows them to identify pregnant members and then link them to care coordination and case management services. And then second is with public health. And so with health departments, so specifically with the administrative care coordination units, it really helps connect them to that public health system of care. So providing assistance, navigating the healthcare systems, and then to address that social determinants of health and those social needs of the health by connecting them to necessary services. And we'll be able to hear more from our health department partners today. And then also as a provider, it helps with that developing that plan of care for the birthing person that's at risk for low birth weights, preterm deliveries, and other conditions as well. So that just really wanted to emphasize how important that Maryland prenatal risk assessment is to connect them to these various services that are available in the community. So thank you so much for this opportunity to introduce the Maryland Prenatal Risk Assessment. And I would like to pass it off to Ms. Miriam Pierce from State Medicaid at the Maryland Department of Health to talk more about the COMAR requirements.
Thank you, Dr. Shu. Good morning, everyone. Thank you to the Hyphen Health team, Dr. Shu and her team, and our local health department administrative care coordination unit for agreeing to participate to set this webinar up to get the word out to the provider community about the critical importance of completing this risk assessment tool. As Dr. Chu has already mentioned, it's a key tool to identifying pregnant women at risk. And so we want to do everything we can to encourage its completion to ensure women are connected not just to health-related services, but also additional services that will promote a positive birth outcome. So the Code of Maryland Regulations, which are the rules, if you will, that guide the Maryland Medicaid Managed Care Program. COMAR 1067-0504 specifically requires that the Maryland Prenatal Risk Assessment be completed at the initial visit. That is for all women that are enrolled in Medicaid. If your practice is not completing the risk assessment at this time, we urge you to provide training and education to your staff to ensure compliance with state regulations and also with best practices. In terms of the form itself, as I've said, it's completed at the initial visit, and within 10 days of completing the form, it is then sent to the local health department care coordination unit in the county where the woman resides. There are fees, reimbursement associated with completing the form and completing or developing a plan of care. Providers receive a $40 payment for completing the form, that is per submission, in addition to completing a plan of care at that first prenatal visit. Subsequent to that, which didn't make the slide, and I'm sorry for that. At subsequent prenatal visits, provider may also be reimbursed an additional fee for completing an enriched maternity health services form. It's sort of a checklist that we've provided to providers. And again, it's an opportunity just to review some key topic areas to ensure a healthy pregnancy and birth outcome. They should talk about things such as smoking cessation, diet and nutrition, making sure she's connected to those services such as WIC and other support services. So there is an additional fee that providers may be reimbursed for. If the provider is contracted with one of our 9 MCOs or multiple MCOs, I do recommend that you check with your MCO, as they may have some additional reporting and requirements for completing the form in terms of reimbursement. As I said, women, so once the form is completed, it's sent to our local health department care coordination unit. They triage the forms and then make the necessary referrals and linkages to health-related services, which might include linking them to prenatal care services with their managed organization, certainly nutritional support services such as WIC, substance use disorder treatment services, and preventive health services that may be available in the local health department or in the community. So as was shared in Dr. Chu's slides earlier, excuse me, and now the risk assessment is a key tool that helps identify those pregnant women who are vulnerable and at risk for adverse outcomes. And so again, on behalf of the Maryland Medicaid program, I want to strongly encourage providers to complete the form. If you or your staff have questions, please reach out to your local health department care coordination unit. Their contact information is listed on the back of the ePRA. You may also contact my office for additional questions or assistance. And with that, I'll say thank you.
Sorry about that. I didn't realize I was muted. Good morning, everybody. I am Amy Radion. I am the outpatient social worker for the University of Maryland Women's Health Center and am thrilled to have electronic medical, the electronic PRA in our office. We've had it now for a little over a year, and it's been fantastic. The time that it saves us from chasing papers has been excellent. And I know the benefit of everything that Dr. Chu and Marion just talked about is getting our patients connected to services in the community. I think that's the greatest thing about the PRA because it's community specific, that if you're coming to Baltimore for care because you're high risk and you live in PG County, you're going to get connected to services in PG County, not Baltimore City. So I think that's the big benefit, is just doing that for the patients. But from a standpoint of the actual physical completion of the form, this clicking process is fantastic. You just go click, 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 and it's done. There's no papers to chase. It stays in the electronic medical record. We have a fabulous system set up here in our office. I'm the one who typically does the PRAs. If I'm not available and I'm out, our medical assistants are the backup to that. Our nurses also complete them if the patient's first entry into care with us is with that. And we would go days searching for papers if we couldn't find one and all of these things. So just the ability that it's housed in the electronic medical record. And you can see on this slide, there's no longer, we do not have to fill out any of the demographics anymore. It's pulled automatically. We just have to click these few things and we're done. It's fantastic. I think next slide goes a little bit more into what we do with this, is that it's, you know, we are very dedicated to doing this, right? Because we know the benefit to the patients and we also know the reimbursement that we get. So we've always, from the day I've been here 13 years, from the day we've always been doing those papers, and now to have it electronic is fantastic. We have a great Epic team that worked with us. You know, we had some kinks to work out in the beginning, making sure it was pulling the exact MA number and not the like members number if they have priority partners, making sure it's the actual MA number that we need, making sure we had all the correct fax numbers for all of the local jurisdictions and all the insurance companies. So we literally, at the end of the day, one of our staff, it's her assigned responsibility. She looks at all the new patients, she goes in, opens up their chart, clicks their name, clicks the letter, clicks the insurance company, sends it, clicks the jurisdiction they're from and sends it, and it's done. It's in the chart forever for everybody to see. I think that it's been such a time saver for me personally that I'm not running around at the end of the day looking for all of these papers. And then if a paper got lost on my desk and I find it and I'm like, oh goodness, this didn't get done, so now I got to run and get it done. It's just been a huge benefit. And we've worked really hard at finding the flow that works in our office. And it's something that it's great. I can't say enough about how great this is. And it's just so time consuming to have to find the paper, make sure you can, find out where it's at, because it's floated all through the office with a piece of paper, right? With it being in the chart, it doesn't. And the other big thing is, and I don't know if there's anybody in here from either of the health departments, that you can read it now. There's no illegible, I can't read the name, I can't read the number, because everything is typed, it's clear, and it's easily seen. I can't say enough of how great this has been for us, and for me personally, just a time-saving mechanism for do these. Because let's say I meet with a patient and I forgot to check off all the boxes in the PRA. I can run in my office and go click, 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 and it's done. I don't have to run around and chase the paper. So it's been great for us. Again, whatever, we're in Epic. I don't know what everybody's electronic medical record is, but to be able to do this is fantastic. And the screenshot that Dr. Chu showed of the actual form, that letter now saves in the patient's chart. So if we would get a call from the local health department or from somebody else, that we can just go in and print it and resend it to them. Like if somebody's fax machine wasn't working, or we found out on our end it didn't go through, it's very easy for us to refax it through the system or print it and fax it the other way. Really quickly, how it works in our office is when the patient comes in for their first visit, if their first visit is what we call an education visit with our nurses, the nurse will complete it as they do that education visit. If their first entry in is an actual visit with the provider, whether it's the physician or the nurse midwife, I'm the one that completes it at that first visit. And then we have a designated front desk staff person at the end of the day, pulls the schedule, sees all of the new patients, and goes in and completes it. Our electronic medical system also has a fax queue where you can go and check it to make sure there was no error faxes to confirm that they all had gone through. It's kind of how what the setup is in our office. And when we get to the Q&A section of this, I can gladly answer if anybody has more specific questions about how to make it work in the office. So thank you all very much for the opportunity to talk today.
Good morning. I'm Pamela Borer-Brown from Baltimore Medical System. I'm Director of Maternal and Child Health. We are a federally qualified health center working in Baltimore City and Baltimore County. We have participated in the pilot for, I would say, over 2 years now, beginning from the time we were actively involved when Baltimore City was hit with the ransomware attack and had a bit of a hold up there. And then through COVID, we have continued to work on it. So we have definitely found that it has made lives easier. As Amy just pointed out, it's extremely important. Providers were always very, let's not say upset, but the fact that they've been working exclusively electronically for a number of years and having a piece of paper thrust at them at a new patient visit was not a welcome sight. And pushing all that paper around in a very large practice is difficult. I'd also like to begin by thanking the Baltimore City Health Department and Baltimore Healthcare Access, who was our test to see if actually they were coming through electronically and we were getting things where they were supposed to be. So participating in the pilot has been a step-by-step process. We are not on Epic, as a matter of fact. We have a next-gen electronic health record system. It's a smaller system that's used by a number of federally qualified health centers. And what we found was that we needed to have a multidisciplinary team to do the implementation. So our clinical leadership, members of our IT department, providers, and frontline staff were all involved in initial meetings as to how this needed to operate. So just getting something within NextGen that looks exactly like that form Dr. Chu showed us was very important. So a lot of the data is pulled from the system to populate the form, and other things the providers do need to go back at first visit, as Amy said, very important. It's filled out on the first prenatal visit to go. So in our team, it's normally the midwifery team who do fill out the form, although the medical assistant working with each midwife then is going to make sure that everything is completed and will then scan over to our perinatal case manager, who sort of does a last eyeball check and then faxes to the local health department. And we do deal with a number of local health departments because we have folks who come to us, especially the uninsured, from surrounding counties. So we're looking at a large geographic area, and it's been much simpler to get things where they needed to go in a timely fashion. So knowing that it is timely, efficient, and a secure data transfer, it's really improved our communication with the local health departments, the MCOs, and among our healthcare team. So that allows us to better gather quality data and care coordination for patients. I do have to say, as was indicated in the first presentation, the $40 reimbursement does not apply to FQHCs. We have other types of agreements that cover care. However, as part of our quality assurance, we believe this is extremely important because the PRA is a very valuable instrument for us to be able to get data together. I also want to back up what Amy said. The workflow is extremely important, especially in this time of great turnover of especially frontline staff. So it's been very important to us. It's very clear. We have 4 sites that provide prenatal care. So we need to make sure that we are working with the charge nurse in each OB section to make sure that the process feels comfortable for her staff and is able to be followed through. So prior to the establishment of the electronic PRA, the average completion rate was 65% in Baltimore City. And as you can see on the slide, post ePRA, it's up to an 83% completion rate. During this time that has been so significant of staff turnovers. So it's really been a boon to us to be able to make sure that patients are receiving the support services they need. They are able to have this done in a timely manner. An old problem with paper had been sites tended to batch the forms and would gather all the paper together at the end of a week. And there were already 7 days into a 10-day time frame to get things put out, which really put my perinatal case manager at a disadvantage, trying to send out hundreds of PRAs to the various health departments. So it's been a huge boon to us and something that we continue to advocate for the use of, and really has improved care on a number of fronts for us.
Good morning, everybody. This is Laura Wood. Can you hear me okay?
Yes, we can hear you great.
Perfect, thank you. I'm Laura Wood, and I'm the supervisor with the Care Coordination Program at the Anne Arundel County Department of Health. And this is very exciting for us to be a part of this. I started doing outreach with our program to the OBs about 15 years ago before I became the supervisor. So to see this evolve into where we are now is just, it's very exciting, and we're really happy to be a part of it. And as other people have mentioned, the time saver it's going to be, and being able to get legible forms and making this easy for the OBs to submit so that we can link our members to services they need is going to be wonderful. So what happens when the form is faxed to us electronically or paper is our team of care coordinators, we have 7 of them, and we have bilingual staff as well. We first go into the MMIS system and we track their eligibility and ensure that they are connected with an MCO. If they are not connected with an MCO, or if they need to, because we do get uninsured or people that are eligible for Medicaid but have not applied, then we connect with our eligibility and enrollment team and make sure that someone contacts them from eligibility and enrollment to help them apply for medical assistance. If everything looks good in the MMIS system, then we enter the MPRA into a database, and we save this in our electronic medical records system, and we contact each person. We have, fortunately, we are able to email them and ask them to call us if we leave them a message. So we email them, and then we also mail a brochure to every single person. They get a really huge packet of information with all the Medicaid brochures and linkages to programs through the health department and the community. And our success rate in reaching people is about 60 to 70% overall. And so once we talk to them, we let them know everything about their benefits. We help them navigate the system. We connect them with their MCO prenatal case management team. We make sure that they're aware of all the Medicaid services that they are eligible for, from mental health and dental. We let them know how and when they need to reapply for Medicaid. We connect them with a pediatrician for their baby. And as Ms. Pierce had mentioned, a lot of the services, smoking cessation, WIC. So we really give them a wealth of information, and we can provide that to them as well in an email and a mailing. So we connect them with everything that we can. And a lot of times, even years later, they will remember our care coordination team and call us back if they're pregnant again, or if they need to connect with services. So they do know how to connect with ACC once they have delivered. And we are very fortunate here in Anne Arundel County to have a Healthy Start home visiting program. So for our highest at-risk members, we ensure that they are referred to Healthy Start, so that way the Healthy Start home visiting nurses can reach out to them and connect them with other peer support services. And that's only for the highest at-risk members, such as our substance use disorder members, and if they have a history of mental health. We fax every MPRA that has an MCO listed to the MCO case management team, so that way the prenatal case management team can outreach to them as well. And that's how they get their stipend payment. And if they do not have an MCO, or if they are uninsured and working with the eligibility team, then we fax everything to the Maryland Health Department team up there, so that way they are aware of the forms. And as everybody has stated, the entire electronic MPRA process is going to make things a lot easier. And we have seen our numbers increase from OB providers that were not submitting the forms in the past. And outreach and education has always been the way into the offices. So we're really excited that we have a consultant now on board working with Hyphen Health to get everybody connected. And I think we have about 6 providers so far that are onboarded. And we're working every day to get more. Hyphen Health has been amazing to work with, and we're very, very excited about this. In the past, we've had to connect with the OBs constantly for missing information, and we have a very good relationship with our OBs, so they are aware of the importance of the forms, and they will call us if they need assistance locating a member, or if they need to try to link a member with services. So the OBs are aware of the importance of the forms, but it's always been a time component that their office just may not be able to submit the paper forms. So they've given us some positive feedback about how they know it'll be a time saver, and they're pretty sure that, they're saying that they think it'll be a lot easier for them to send the forms to us. So we're very, very excited, and thank you guys so much for having us participate. Take care.
Good morning. I am Janelle Oliaby with Healthcare Access Maryland, the Care Coordination Program. I serve as the Deputy Director. In Baltimore City, the Care Coordination Program at Healthcare Access Maryland actually provides the administrative care coordination work on behalf of the Baltimore City Health Department. So when the prenatal risk assessment is faxed to the Baltimore City ACCU, we receive them electronically, regardless of your method of fax, so that we can receive those fax 24 hours a day, 7 days a week. For our providers who might be overachievers and want to make sure that they're completing their tasks by accessing their EMR over the weekends or late into the evening, that PRA will be received by the Baltimore City ACCU, regardless of the time frame that it's submitted. Once we receive it, we have an administrative team that is responsible for reviewing the prenatal risk assessments for legibility, clarity, as well as we want to make sure that we can truly recognize the time frame that this patient has been referred to the local ACCU for engagement, so we can triage the most immediate. A copy of that prenatal risk assessment is sent to that client's managed care organization if it is identified that they have a managed care organization. If one has not been identified, we are responsible for sending a copy to the Maryland Department of Health. The managed care organization has a responsibility to initiate telephone outreach for their members so they can start completing their health risk assessment and triaging their members for engagement with their prenatal case managers. Our outreach team is responsible for completing eligibility verification and making sure that the members that were referred have active medical assistance. And if there is any gaps in their services, we work with our local eligibility entity to help resolve those barriers. The cases are assigned to our outreach team, which is comprised of registered nurses, licensed social workers, and a host of community health workers. And it is our goal to initiate telephone outreach within 48 hours of receipt of that referral. At the conclusion of our telephonic outreach, which we are hoping will be successful with the members, we have 10 business days to facilitate that outreach and document our summary and provide a copy of the summary of that outreach back to the referring provider, as well as we give an update to the managed care organization of the goals of our outreach. In Baltimore City, the local ACCU, or Administrative Care Coordination Unit, has a centralized intake system for the Maryland Prenatal Risk Assessment, as well as a number of other referral forms that are connected to the maternal and child health population. We work very closely with the Baltimore City area OB providers, as well as the Medicaid managed care organizations, to make sure that these clients are assessed promptly, triaged, and connected to necessary services. The benefits that we have seen with the electronic PRAs that are being submitted by our 2 pilot sites in Baltimore City is, number one, that immediate clarity in writing. There is no discrepancy in terms of the phone numbers that are documented, which is our most significant method of contact for clients that are referred. We also see that clients who are screened at their initial prenatal visit, there is not a lag in time of submissions of these electronic prenatal risk assessments. It's essential for our team to engage these women when they've had early access to prenatal care, so we can help mitigate any barriers that could impact an adverse birth outcome. It's our responsibility to make sure that we achieve certain goals during our outreach. The first is education. We want to make sure, in addition to that woman being connected to a prenatal care provider, she also has a medical home where she is receiving preventative health care, as well as if there are any chronic health needs, she is receiving specialty care as identified. And if there are any problems, we work with our Maryland Department of Health team to resolve any issues with access to care or any complaints that are needed to be filed for our health choice enrollees. We want to make sure that we link and coordinate care for our clients to dental care, preventive health screenings, lead screenings, immunization, family planning services, as well as behavioral health services. And ultimately, we want to ensure that after we complete our short-term care coordination, that every pregnant woman is educated about a home visiting program connected to WIC, infants and toddlers, if deemed appropriate, as well as the managed care organization's prenatal enrichment programs and their chronic disease case management programs. Lastly, if we discover that there are some barriers that this woman is experiencing to maintaining healthcare, we want to try to remove those. So we educate them about medical assistance transportation. If there is a need for translation services to ensure that they understand what is happening during their visits, we want to make sure that those methods are in place as well. And lastly, it's our responsibility to make sure that the member understands the role that the managed care organization serves and who is available to follow them for case management if necessary. So we make direct referrals to the managed care organization's special need coordinators and if necessary after delivery to the newborn coordinators. Thank you for your time, and I will pass to the next presenter.
Well, thank you so much, everyone. And thank you to all the panelists as well. And thank you again to Hyphen Health, who's been leading this work with us as well. So, and then finally, thank you to everyone who's been listening to this webinar. So to conclude, some of the big takeaways from today's webinar. First, you heard how important that ePRA form is of that linkages to community care. And then two, the big ask for everyone today is to consider for your practice to go electronic to support mothers and families. And so we want you to be energized for your practice to take that ePRA form and make it electronic and use it in your practice. And we want you to do that because one, it really closes the gaps because filling out the form fields occurs as birthing individuals are seen by the provider. And then two, what you heard today from two practices who already went electronic is that it creates those efficiencies and it ensures that timely delivery of that prenatal risk assessments to that local health department, to the administrative care coordination, so that they can connect to care rather than having those batch deliveries. And then three, what we also heard today from the two practices is that it provides that clarity and quality in the forms because there's no further issues with legibility. And so from the public health perspective, this going electronic, it will save even more lives and then increase health equity. But the value added to you as a provider, as to your practice, is really decreasing those administrative burdens because everyone is so busy and everyone has been working hard, especially the past several year and a half during the COVID pandemic as well. And then finally, the fourth takeaway is that all of this, it is doable. And we're here to support your practice when it's ready to go electronic. And so I think this is a good time to now turn it over of the next steps. So I will turn it over to Hyphen Health on the next steps.
Thank you so much, Dr. Chu, and thank you to the entire team of panelists. What a fantastic cadre of individuals coming together to support the lives of pregnant women and their families. Cannot thank you all enough for the incredible work that you are doing day to day, especially in these trying times. So what is the process for going electronic? First of all, we are working closely as part of this pilot project with the Baltimore City Health Department, with the Baltimore County Health Department, and with the Anne Arundel County Health Department to ensure that 5 pilot sites are moving forward. In those jurisdictions, we are working with the individuals listed on the slide that you can see. But in that process, we work closely with you all to ensure that we document the workflow around the prenatal risk assessment before integration, ensure that the translation of the ePRA form into an electronic process, ensure that we're troubleshooting and testing, right? So anything that we do, it happened, you can integrate it, but you always want to test it and make sure you're troubleshooting any challenges that may come up. And then finally, as mentioned by the folks who've already integrated the electronic form into the electronic form, that really documenting that workflow and ensuring that everybody knows their roles, their responsibilities moving forward is a critical piece of the next of the smooth transition before going live. And so that process can vary in terms of the amount of time it takes, but really the key is to ensure that we have a strong champion for the work, partnership from the IT department, and strong communication all around. We're embarking on this project and this journey. We've already started, but looking forward to continuing this path as we look to expand access to 5 sites in coordination with all of our jurisdictions leaderships, increase the submission of the ePRA, and improve linkages to women in care. and of course, raise provider awareness. So even as we wrap up this work, as we continue and wrap up this work, we want to ensure that we're really moving that agenda forward, sharing the story continually around the value of this prenatal risk assessment. It is statewide and is a mechanism to make sure women are supported during their pregnancies. If you're interested in learning more, please do feel free to reach out to us at hyphenhealth@gmail.com, and we will continue to share this information and keep in close coordination with all health departments and ACCUs. From our lessons learned, and Dr. Chu can, I am sure, speak to this further, as well as the entire team, that we want to be able to reach all pregnant women through eligible for services through this process. Thank you so much for joining us today. I am going to pause here. Again, thank you so much to the panelists. What an incredible cadre of individuals, bringing together all their work and how the system really connects. As COVID has shown us, and repeatedly we find in times of crises, that a strong health system is one that can serve our clients, our community members to the utmost, and one that really moves us and drives us towards increasing equity in our health. So I'm going to pass it over to my colleague, Maya McDoom, and we'll go from there for the Q&A.
Thank you so much, Sadia. Thank you to all the dynamic speakers today. So a couple of questions have come through, and we wanted to kick it off with Amy Sechrist and Amy Radian to take this first question. How does the clinic fax to the relevant health department within the electronic PRA process?
So when we built the whole system, we built like a address book, right? So when the staff go in, they pick the correct one. So what we did with the build was we had our staff person who was faxing them. We had her type us out a list of the name of the jurisdiction and the fax number. And this is what we then sent to our ID department, which they then put in the system. And we actually learned that, I forget which county it was, had to change to the number, because we got a call from them that they hadn't received any PRAs from us and they thought it was kind of strange. So that's when we found out that they had a new number. So that's one key thing that we learned, is making sure that we're checking every so often that those numbers are accurate by going in and looking at, because in our electronic system, like I said, there's a fax queue that you can go in and say, it'll say that the fax did not go through. Right, like it didn't, so that we can go backtrack and we can look and we can see what the issue was. So we basically have an address where she types in ePRA Harford County or ePRA Amera Group, right? Like it literally just gives us the options, and you just go boom and it goes.
Yeah, so just like Amy said, we've been able to use the eFax functionality in all of the different electronic medical records that we built in, which I'm sure if you work significantly in your electronic medical record now, you're probably pretty familiar with. It will send, so it doesn't change the workflow for our ACCU providers, and it keeps things all electronic for the healthcare providers.
And our designated person who does it is one of our front desk staff, who is very familiar with how to send letters in Epic. So I think that's the other key, is identifying the people within your office that are very comfortable and knowledgeable about your electronic system. And she also has a backup. Everybody's got a backup here, right? If I'm not here, it's the MA. So everybody's got a backup for this whole system with the doing of the electronic PRA.
Great, thank you both. Our next question is, who do I contact if I'm interested in integrating the ePRA into my EMR? And I'll turn that over to Dr. Chu.
Oh, great. Well, who to contact? So I would recommend really contacting Health. As you heard, right now there is a in partnership with Medicaid and Public Health Services at the State Health Department. We are really looking to expand in the Baltimore Metro region to expand and to leverage the great work that has already happened with the ePRA work there. So really at this point, contact Health if you are interested in moving towards electronic for the PRA.
Great. And also our next question I'll say for you as well, Dr. Chu, is there an incentive for transitioning to the ePRA?
As part of this pilot work as well, there are some limited funds right now to engage pilot sites. And this is in partnership with Hyphen Health and then also with the Baltimore City Health Department.
Great, thank you. And I'll take the next question. So the next question is, how long will the ePRA integration process take? So from what we've seen working with the health departments as well as the clinic sites, it's taken as quick as 1 week to do the build out to several weeks to do the build out. It's really dependent on the IT capacity and the coordination with the key stakeholders in the clinic. I think the rate limiting factor is ensuring that there's training for folks in the clinic to understand the new process and workflow. And I think once that is worked out, that's when you can go live and really start transitioning to submitting on a faster pace. All right, our next question is also for Dr. Chu. Is transitioning to the ePRA mandatory at this time?
Right now, it is not mandatory, but we want to encourage practices for the reasons that were listed in the webinar today. And then from a population health perspective and from a public health perspective, really with the focus on the statewide integrated health improvement strategy, we do think this will help also for maternal and child health outcomes.
Great, thank you. This is also a question from a live question from the audience. So could you talk about how providers understand what services patients receive? And I'll kick this over to Marion Pierce, Laura Wood, and or Janelle to answer these questions.
Could you repeat the question again, Maya?
Oh yeah, sure. Could you talk about how providers understand what services patients receive once the forms are faxed over to the health department?
So is there like a letter or something mailed back to the provider?
So the way the ACCU program is set up in each of the local health departments, we provide them broad guidance in terms of the scope of work expected to be performed as they provide administrative care coordination services. But we do allow each jurisdiction flexibility in terms of how they then go about setting up the scope of work, including working with providers. So I'll let Janelle and Laura speak for their jurisdictions.
In Baltimore City, we engage in provider outreach meetings on an annual basis to educate providers about the services that are available to the maternal and child health population, as well as once any referral is submitted to our jurisdiction. Once we complete outreach, we send a written summary back to that provider, so they are aware of if we successfully engage with their patient, what services we connected them with, or if we did not successfully engage with their patient, so that they can remind them that they receive phone calls from us and the door is still open for them to reach back out to us to learn about service provision.
I can follow up with Anne Arundel County, and so we go out quarterly to our providers, and we have a provider folder that we give them all the information, how to connect with ACC, and we give them brochures so that they're aware of all the services and programs and resources that we will be providing to the patients. We do not follow up with them with any written letter or form. We've let the providers know that when the MPRA is sent to the care coordination unit, that it goes to the MCOs for case management, that the ACC care coordination program follows up and links them with resources. We've kind of put the ball in their court to let the provider know that if they need to follow up with the health department to find out, if we did connect with the patient, they know how to contact us. We have a roster that we have given each provider with all the care coordinators, phone numbers, email addresses, and they can follow up with us. If the MPRA ends up going to our sister program in the health department for the home visiting program, Healthy Start, the Healthy Start program does send a letter to the OB provider letting them know that they have enrolled the patient into the Healthy Start home visiting program because they're at risk. And we have had a good turnout with the providers contacting us. We have a really good relationship with all our providers, so they will contact us directly if they have questions or want follow-up. And I feel like they're pretty connected with the resources in the county. So that's how we do it in Anne Arundel County.
And Maya, I'd like to add to that from our office is a residency office. So we have multiple providers coming in, and we have our attendings who also have their own office in the midwife. So I think that for us, it's really important that the support staff in your office is very aware, because you could probably quiz some of my residents and they would not know what you were talking about. So I think if you have a social worker embedded in your office like we have, and that your support staff, your medical assistants, your nurses, that the staff, even your front desk staff, that your staff in the office are aware of this service. So if they hear a doctor saying, well, this patient needs all this help, they can say, oh, did you do the PRA? Because this will connect them with services. So I think that that's another big benefit of this, is making sure the support staff in the office are very aware of what this program can do and what this connects the patients to, because that's going to help get the patients connected to the services.
Great, thank you, Amy. That's an excellent addendum. All right, next question is for Sadia. Could you tell us what EMR systems have already been integrated into the ePRA process?
Sure. So we know that Epic and NextGen are already integrated. There are a number of others that are on the way, but we're, of course, able to work with anyone within the capacity of their IT support, as well as their support and championship from the office staff and nurses. We also work with smaller, sort of off-the-shelf forms, building EMRs, and we work with MacPractice in that capacity as well.
Great, thank you. And I'll take the last question. Is there a toolkit or a how-to on how to help providers as they consider transitioning to the ePRA? Health is working on that, and we plan to take some of the lessons learned from the actual pilot over the next few months and scale that up into a toolkit in terms of a how-to, kind of what you need on the ground to get ready, what are some lessons learned from the clinics who've been successful. So thank you so much, everyone, for your participation. If there's no other questions, we just really appreciate your participation, your feedback, and your insight, and we hope that you are energized to participate in the ePRA pilot process. Thank you again, everyone.
Thank you.
Thank you.
Thank you.